Yeah, a very good evening to all of you. And many thanks for having me here. Really excited that finally we are having first oncology meeting here in Bangladesh, a session which is entirely dedicated to cardio oncology. My name is Dr. Vivek Agarwala. I am Director Medical Oncology and Hemato-Oncology at Narayana Health, Kolkata. And I'm also the founder, General Secretary of Asian Cardio-Oncology Society. Yeah, yeah. And to see if the slides are just so till the time they get the slides on the screen, let us have some interaction. Today my topic is on preventing anthracycline cardiotoxicity. And how many of you really think that today we can spare anthracyclines? You know, when we go abroad and when we listen to all those foreign speakers, they all speak about anthracycline sparing regimens. They speak about treating with polatuzumab and not introducing anthracyclines in DLBCL. They talk about antibody drug conjugates and pertuzumab combinations, and avoiding anthracycline in HER2 positive breast cancer. So, just to ask, how many of you think we can spare anthracyclines? Just a show of hand. Does anyone think here that we can spare anthracyclines? Correct. So I think, no one has showed their hand, and everyone believes that we need anthracyclines in today's era. Our patients do not afford those costly molecules. Anthracyclines are very much essential. I think the slide is there, and it's moving. Yeah, it's moving. I do not have any conflicts of interest. And but I want to state that I'm not a cardiologist or I'm not a cardio-oncologist. It is I don't know, by the fate that I have been here in Bangladesh 3 times, and all 3 times I have been invited only for cardio-oncology. I'm never invited for a medical oncology talk. But thanks again. But I am a medical oncologist and I have a very special interest in cardio-oncology. I'm not a cardiologist or a cardio-oncologist till now. So, we will talk about cardio-oncology and Asian Cardio-Oncology Society. We'll talk about anthracyclines and the cardiotoxicity, the preventive measures that we can build. And we will look at a case of breast cancer and a high-grade lymphoma with anthracycline cardiotoxicity. Look at how we are managing with some focus on today's topic, that is liposomal doxorubicin. So why, cardio-oncology? Cancer and cardiovascular diseases, they are the two most common causes of morbidity and mortality worldwide. And from Asia, we contribute the maximum number of cases to this. And the trend is always increasing day by day. With increasing age and increasing life expectancy, we have more cancers and we have more cardiovascular diseases. And with better cure rates in cancer and better treatment, now we have more survivors and we have more patients with cardiovascular diseases due to chemotherapy. So, maximum patients in any cancer clinic, they already have cardiovascular comorbidities, or they are going to end up having some cardiovascular problems during their treatment. And now we are already talking about the reverse cardio oncology, that is the causing of cancer because of cardiac problems. There is already talk of obesity leading to cancer. There is already talk of diabetes predisposing to cancer. So there is already a talk of reverse cardio oncology happening. Now, what is cardio oncology? It is like a true coordinated teamwork between the cardiologist and the medical oncologist, both working towards improving outcome of the patient. The idea is to prevent and treat whatever cardiotoxicities that occur during or after treatment. And the idea is not to stop oncological treatment. The idea is to continue optimal life prolonging oncological treatment despite moderate to mild cardiotoxicity, giving confidence to the oncologist to continue the cancer care, keeping the heart well, keeping the heart healthy, and continue the cardiac care. Now, we definitely lack a cardio-oncology, effort team in most Asian countries. There are only handful of centers that are running proper cardio-oncology clinic, and it is definitely difficult to bring cardiologists to a non-interventional branch like cardio-oncology. I was, told that we have cardiologists today attending this meeting. So, are there any cardiologists? Any cardiologists here present in the meeting? You see, Beacon told me that they have invited cardiologists. And again, I say that it is so difficult to bring cardiologists. Okay. So we have one cardiologist in the meeting. And
Yeah, well,
I
I
would
am
say that
attending
we are all
virtual, Dr.
fortunate
Vivek.
that at least one cardiologist is there to, sort of look at this non-interventional branch of cardio-oncology. Thank you, sir.
Yeah, Dr. Vivek, I am there. I am attending a virtual
So,
meeting.
2020, we all got together to start this Asian Cardio-Oncology Society. It is already a 100+ member society. We have members, representatives from many of the Asian countries, and from Bangladesh, we already have Dr. Arman and Dr. Syed Mohammad Akram Hussain as our representatives. And including this, we have already conducted 14 meetings on in Asian Cardio-Oncology Society. The last one was also a physical meeting that was conducted at Indian Cancer Congress last year. And thanks to Beacon, that today we are all here to attend this cardiovascular care in cancer patients seminar. And it is my request to all of you to please come forward and join Asian Cardio-Oncology Society. Dr. Arman is already there. Dr. Mohammad Akram is already there. And they can help you to join this society. I would encourage cardiologists from Bangladesh to also join, so that, we together can participate in improving cardiovascular care in cancer patients. Now, coming to today's topic, and we all have agreed that anthracyclines are, really important. They are very potent drugs. They come cheap. They are already on the WHO list of essential drugs, and they are the backbone of management of lymphomas, breast cancer, sarcomas, pediatric malignancies, including leukemia. They have all significantly contributed towards improving overall survival in all these conditions. But cardiotoxicity has been an age-old concern, and anthracycline is the leading cause of chemotherapy-related cardiotoxicity or chemotherapy-related cardiac disease. So, how does anthracyclines act? So we all know anthracyclines, they inhibit topoisomerase 2, which prevents the DNA uncoiling and prevents DNA repair. But there are two isoforms of topoisomerase 2. That is the 2 alpha isomer and the beta isomer. And alpha isomer is something which is very overexpressed in tumor cells, which explains most of the anthracycline anti-tumor activity. But the beta isoform is present in quiescent cells of the body and also in the cardiomyocytes. Anthracyclines also act by forming adjuncts with the DNA, thereby causing DNA double-stranded breaks. And one of the recent mechanisms is that has been propounded is the reactive oxygen species generation. So these reactive oxygen, they damage the DNA, they damage the intracellular membranes, and they also cause mitochondrial damage. Now, why does anthracycline cardiotoxicity occurs? And if you notice that in this slide, you can see that doxorubicin, it attaches with I don't think this is working. Anyways, doxorubicin attaches with the carbon with the iron, and this iron doxorubicin complex, it when it moves inside the cell, it causes generation of reactive oxygen species, and this reactive oxygen species causes mitochondrial damage, causes lipid peroxidation, causes impair in the calcium handling. It also causes energy depletion. We all know mitochondria is the energy powerhouse of the cell, and when this mitochondria is damaged inside the cardiomyocytes, the cardiac myocyte goes apoptosizes, it dies, and there is vacuolization inside the heart. And, very interestingly, if you see, what you will notice in the above, diagram is that if uh, the total number of cardiomyocytes, they are fixed and they are at the optimum and the most maximum level at around 18 years of age, after which they progressively continue to decrease if it is a normal person with a normal heart. And if you give them anthracyclines early in life, what you can notice is that there is a progressive drop in the number of cardiomyocytes because of the injury, and they are never able to attain a higher level of cardiomyocytes. And then we can easily see and understand why these individuals, young individuals who receive anthracyclines early in life, have a higher tendency to have cardiac failure later in life. And also in individuals who are elderly, who are already having less number of cardiomyocytes, if you give anthracycline, there is decrease in the number of cardiomyocytes due to injury, and which precipitates heart failure. Obviously, if you have other cardiac events like a myocardial infarction, then these cardiomyocytes also go low. And then if you give them anthracyclines, they will further go low and it will cause heart failure. So this, makes us understand why, early age or higher age is an important factor. And the injury to by anthracyclines, they start right from the first dose itself. There was a study which was conducted which showed that even after the infusion of anthracyclines, if the cardiac troponins were measured, they were found to be high as compared to normal individuals. Regarding onset, duration, and incidence, so acute onset is something that occurs immediately or during the first dose of anthracyclines. Usually these are arrhythmias or something like pericarditis, myocarditis syndrome causing chest pains. They are very rare. Less than 1% of patients have it. Uh, Usually it is chronic, and chronic is divided into early onset, which is less than 1 year after completing anthracyclines. And this is up to 2% patients can have cardiomyopathy, which can be progressive. And late onset is after 1 year of completion of treatment with anthracyclines. And this is, of course, more pronounced, as we discussed earlier, in childhood or young patients. This is the spectrum of anthracycline cardiotoxicity. We all understand that initially there will be only rise of cardiac biomarkers without any decline in left ventricular ejection fraction, which is called a type A cardiotoxicity. Type B is when you have an asymptomatic decline in left ventricular ejection fraction, and then it is type C, where there is a frank heart failure and a symptomatic LVEF decline. And obviously, when you are detecting it earlier in the spectrum, it is more reversible, and as advanced it is there in the spectrum, it is less reversible. Regarding the incidence data, so if you look at the older data, what you see is that in children, it is said that when you give a 300 milligram per meter square dose of adriamycin, the incidence is close to 5% and starts increasing so that it almost becomes 25% at 450 milligram per meter square. But when you look at the recent contemporary data, the contemporary data says that the incidence of absolute 10% decline in left ventricular ejection fraction is around 9%, and most of it occurs within the first year. There's a separate meta-analysis of around 50,000 patients, which again says that at a follow-up of 9 years, 18% patients have a subclinical cardiotoxicity and 6% additional have a frank clinical cardiotoxicity. Now, risk factors. Risk factors, again, we can classify into modifiable and non-modifiable when it is patient-related. So, of course, we discussed how when it is age is high, the risk is high. Female gender, the risk is high. Genetic polymorphisms are also important because the anthracyclines attach to top 2 beta. Now, there is a study which tells that if patients have less top 2 beta on their cardiomyocytes, then they are spared of anthracycline toxicity. So, if there is a top 2 beta polymorphism, then these patients will not have cardiotoxicity. Also, patients who have iron metabolism disorders and have more tissue iron, something like hemochromatosis, they are going to have more cardiotoxicity. And there are also polymorphisms. For example, in UGT1A, polymorphism causes more cardiotoxicity. So there are many genetic polymorphisms that are recently coming up with more and more molecular understandings, which tells us that these patients are at higher risk of cardiotoxicity. Of course, the traditional cardiovascular risk factors like hypertension, diabetes, smoking, past history of heart failure or a coronary event, sedentary life habits, all these contribute to risk factors. And regarding the therapy related risk factor, the most important is cumulative dose. Infusion regimen, concurrent treatment, they are also important, because if patients are treated concurrently with radiotherapy, again, if the patients receive concurrent trastuzumab, so we can naturally understand they are going to have more incidence of cardiotoxicity. This is the dose equivalent, and what we know is that all the anthracyclines, they are nearly equivalent in their dose efficacy as well as cardiotoxicity potential, and the incidence of cardiotoxicity corresponds to the cumulative dose. And when there is a frank heart failure, it is usually irreversible. But there are studies that have shown that cardiotoxicity or due to anthracyclines now with prompt heart failure treatment can be reversible. And how do you know it is because if you do a CPET stress testing, then there is a reduced peak oxygen consumption, VO2 max, and this can be used as a predictor to see how is the cardiac recovery and whether there will be a survival or not. Anti-HER2 agents, trastuzumab, we all know the pathophysiology is because of the HER2 in the cardiac tissue also, which is important for cardiac response and repair. And when anti-HER2 agents are given, these anti-HER2 agents also damage the cardiac tissue. The toxicity is maximum with trastuzumab and least with the TKIs. And what we have to understand is that the trial data says that the incidence at around 5 years is around 9%, and it becomes 18% when they are given with combination of anthracyclines. Regarding heart failure, recent data says that frank heart failure is only 2%, but then there are retrospective data which says that if you are given anthracyclines and then you give trastuzumab, then the incidence can increase to up to 12%. And usually we all know trastuzumab related or anti-HER2 related cardiotoxicity is reversible. And we are able to give trastuzumab and related agents even at an ejection fraction of 40% if the patients are asymptomatic. This is the classical comparison, type 1 versus type 2 cardiotoxicity between anthracyclines and trastuzumab. We have to understand that trastuzumab cardiotoxicity is dose independent. There are hardly any ultrastructural changes as opposed to anthracyclines, where there are vacuoles and myofibrillar disruption. And the re-challenge is definitely one which is possible with trastuzumab, but it is not possible, and there is a high probability of progressive dysfunction if you re-challenge with anthracyclines. Now, coming to prevention. So, by prevention, we all know that there is primordial prevention and primary prevention that takes place in normal individuals who are at a higher risk of cardiovascular toxicity, but they are normal. They don't have the cardiotoxicity yet. Secondary prevention is mainly aimed at early detection and prompt management of symptomatic heart failure or asymptomatic decline. And tertiary prevention is, of course, in patients with frank, heart failure, where we are looking to rehabilitate them and improve their quality of life. So, in cardio-oncology, we talk about A, B, C, D, E whenever we want to talk about the routine principles of prevention or primary prevention, where A stands for awareness of heart disease, aspirin, and prevention of peripheral vascular disease by measuring ankle brachial index. B is for blood pressure and utilizing cardiac biomarkers. C is, of course, managing cholesterol, cessation of cigarettes, and cardioprotective medications. And D is for diet management, diabetes management, and dose management of anti-neoplastic treatments like chemotherapy or radiation. And E is for exercise, echocardiography, ECG. So all these basic principles need to be utilized. And if you talk about, more anthracycline specific prevention strategies, of course, we need to do pre-treatment genetic screening. We need to, screen individuals who are at high risk. Pre-morbidities management is must. Try to limit the dose of anthracyclines lesser to the cumulative dose which is allowed. Infusion is something that we'll talk about. Dexrazoxane we'll talk about. Of course, exercise, diet, and lifestyle management will come. And today's main focus, that is other new formulations of anthracyclines we can go to, which is liposomal doxorubicin. Now, regarding infusion timing, the von Hoff's analysis and theorem says that the cardiotoxicity related to anthracycline is due to the peak levels of anthracyclines. So there was a study where they compared a continuous infusion anthracyclines of 48 hours, 24 hours, and 72 hours with weekly low doses of anthracyclines and bolus 3 weekly dose of anthracyclines. And what was found that the efficacy was similar in all the infusions, but the cardiotoxicity was minimum with either a weekly low dose infusion or with the prolonged infusion. However, we all know with prolonged infusion, there was rise in mucositis. It is costly because it increases hospital stay. There is requirement of additional, central lines, IV lines, and it may not be feasible. And further, in pediatric population, it was found that increasing the duration of the infusion was not found to be cardioprotective. Dexrazoxane, it is the only FDA approved molecule which is approved for prevention of cardiotoxicity. And how does it act? It chelates iron and it attaches itself to topoisomerase 2. So it doesn't allow doxorubicin, active doxorubicin, to attach to the topoisomerase 2 beta in the cardiomyocytes, sparing the cardiomyocytes from cardiotoxicity. It is widely used in pediatric malignancies and even in metastatic breast cancer. It is approved when you are using anthracyclines beyond a cumulative dose of 300 milligram per meter square. The efficacy of anthracyclines is not reduced when you are co-administering dexrazoxane. Long-term risk of secondary malignancies is also not higher. However, cost is a limiting factor and availability is a limiting factor. This is one of the trials of dexrazoxane where we can see that when it was combined with anthracyclines, the incidence of cardiac events decreased from 39% to 13%, and the incidence of congestive heart failure due to anthracycline decreased from 11% to 1%, and the tumor response was unaffected. Another meta-analysis of primary prevention with dexrazoxane, multiple studies, 7 randomized studies and 2 retrospective studies, more than 2,000 patients. And what was found here is that significantly less clinical heart failure, less cardiac events with similar PFS and OS. Now, talking about cardioprotective medication, these are all neurohormonal, strategies in order to reduce frank heart failure. Of course, we have ACE inhibitors, ARBs, we have beta blockers. Carvedilol is preferred one because of its antioxidant properties. In ACE inhibitors, ARBs, sacubitril valsartan is something that has shown, good recent evidence. Among the vasodilators, try to use the dihydropyridine calcium channel blockers rather than the non-dihydropyridine. Aldosterone antagonists have also, improved the heart failure rates. And eplerenone is something which is preferable because spironolactone has some pro-estrogenic effects. Statins, they were all thought very recently to be only, anti-atherosclerotic, but now it is shown in recent data that they also prevent left ventricular ejection fraction decline in lymphoma. And there is also data for DPP-4 inhibitors, the gliptins. They can also, have some cardioprotective role. Now, I wanted to discuss the evidence of these all, neurohormonal mechanisms, but there are multiple small studies. They have all taken lower risk patients The trials are very heterogeneous towards what type of chemotherapy, what dose of anthracyclines they have received. So the evidence of all these are low. And the statistical benefit that has been shown in all these trials, we don't know how much it translates to clinical benefit. At least there have been recent two large meta-analysis which confirms that there is significant benefit, but the data is conflicting. What we understand is that ACE inhibitors and beta blockers and statins, they are a backbone and they are a must whenever we are talking about cardioprotective medications. Of course, there are ongoing studies which will throw light on more issues like how long these medications have to be continued for the cardioprotective efficacy and to prevent heart failure, and what is the dose that they have to be used in. Now let us approach this case as to how in a cardio-oncology clinic this case will be approached. So we have a 55-year-old female post-menopausal, known case of diabetes, hypertension, is obese, and is also an active smoker. She is diagnosed with left breast cancer, which is a locally advanced breast cancer T3N1, which is ER positive, PR negative, and HER2/3 positive, and she is referred for neoadjuvant chemotherapy. If you look at the routine labs, it is normal. She is performance status 1. She doesn't have any cardiac symptoms, and her echocardiography shows 55% left ventricular ejection fraction. So, how should we approach this case in a cardio-oncology clinic? Now, the cardio-oncology concept goes by cardiovascular risk assessment. Dr. Anuprita will be, elaborating on how to do a cardiovascular risk assessment in a clinic, and then start appropriate oncological management after the risk assessment, and start preventive measures whenever the patients are at higher risk. Identify these cardiovascular diseases early by proper monitoring, and manage them even post-treatment by survivorship. So these are the baseline cardiovascular toxicity, and this is the Asian Society of Cardiology guidelines of a proper risk assessment strategy for all patients. And by this risk scoring, what we can understand is that we can see that this patient has hypertension, diabetes, obesity, and smoking. And if the cardiac biomarkers was not done, we would not have found that this is actually a total score of 5 and it is actually a high risk patient. Now it is very clear by the cardio-oncology guidelines as to how to manage. If the patients are low risk, go ahead with routine treatment, no need of biomarkers, no need of cardio-oncology referral, no need of frequent monitoring. But if patients are moderate risk, they need monitoring. Some of them may need cardio-oncology referral as well as primary prevention strategies. But if the patients are at high risk, the guidelines say that go for an alternative regimen which is equally effective. Or if you are not able to give an equally effective alternative regimen, try to give it, but do biomarker monitoring, optimize the cardiac status, send to a cardio-oncology clinic or a cardiologist for optimizing the patient status, and have all the primary prevention strategies that we discussed. So coming back to our case, what we find is this patient was a high risk for anthracyclines as well as trastuzumab. So the ideal treatment for this patient would have been probably a TCHP trained to regimen, which is anthracycline sparing. But this patient cannot afford pertuzumab. So the decision was to go ahead with anthracycline based treatment, followed by trastuzumab and taxane based treatment with strict surveillance with GLS, with biomarkers, cardiology referral, institution of cardioprotective medications. So this patient, amlodipine was changed to sacubitril valsartan and carvedilol to have a better cardioprotective effect as well as hypertension management. Statins were added. Patient was counseled for to stop smoking. Patient was referred to physiotherapy department for appropriate exercise. Patient was referred to dietitian for a proper diet for management of obesity, and patient was also alerted. The radiotherapy consultant was also alerted that when you give radiotherapy to the heart, it is a left-sided tumor, you need to decrease the heart doses, mean heart doses. You have to be careful about that. So when you approach a case through the cardio-oncology principles, there are a lot of interventions that you can do to your patient and improve the outcomes. Now, finally coming to liposomal doxorubicin, this is also one of the very important strategies in order to improve anthracycline cardiotoxicity. So what is liposomal doxorubicin? So basically it is a liposomal encapsulation of the doxorubicin. So this liposomal encapsulation actually modifies the pharmacokinetics and the tissue distribution without affecting the efficacy. What happens is the active doxorubicin is actually trapped inside in the internal aqueous compartment, and the liposomes, they are in bigger size. So because of this bigger size liposomes, these molecules, they get stuck in the tight capillary junctions of major organs, including the heart. So these chemotherapeutic agents, the liposomal amphotericin or liposomal doxorubicin, the doxorubicin part is not able to permeate into the vital organs. But when you talk about tumor vasculature, it is already a leaky tumor vasculature. It is already a fragile and a permeable vasculature. So these molecules are able to leak through them, and that is the reason why they are able to have equal efficacy, whereby sparing the heart of the cardiotoxicity. There are two kinds of liposomal doxorubicin. One is pegylated and one is non-pegylated. And by pegylated, what happens is that there is a covalent attachment of surface methoxypolyethylene glycol. So this actually masks these liposomal molecules from the macrophages. Otherwise, they would be attacked by macrophages. It decreases the immunogenicity of the molecule, and therefore the molecules have a greater half-life. They are not easily degradable by the immune system. And pegylated liposomal doxorubicin is the most commonly used form of anthracyclines in patients who already have myocardial dysfunction. This is the mechanism of action and what is classically known as the EPR, that is the enhanced permeability and retention effect. So we can see how these liposomal molecules, they can permeate into these leaky vessels, and not only they permeate, they are retained in the tumor vasculature, because this tumor vasculature, they have limited lymphatic drainage and they are not able to escape this microenvironment, so they are retained also. So this also acts like a resistance to the MDR molecule, the molecule which shifts the active anthracyclines or the chemotherapeutic agents back out of the cell. So because of this EPR effect, they are able to overcome the chemotherapy resistance mechanisms, and these molecules are able to be retained within the tumor itself. So time and again, there are multiple studies that have shown that cardiotoxicity significantly reduced. Although the labeled cumulative dose of lipodox is 550 milligram per meter square, which is almost up to 11 cycles of 50 milligram per meter square, or almost 15 cycles of 40 milligram per meter square, there have been multiple studies that have shown that even when the cumulative dose reaches beyond 1000 or 2000, the incidence of cardiotoxicity is very, very low due to liposomal doxorubicin. Another study confirmed that if liposomal doxorubicin is added to patients who have already received anthracyclines previously, then also the liposomal doxorubicin related heart failure is minimum at 10 years. Of course, we all understand that these molecules, they are not able to permeate out. So that is the reason why they are captured in the capillaries of skin and mucosa. That is why there is higher mucositis, there is higher hand-foot syndrome, and there are higher infusion reactions in the skin with liposomal doxorubicin. Cost again is a factor. Because of the engineering, the cost increases. And the PFS and OS in time and again studies have not shown superior results with doxorubicin. And the reason for this is because the EPR effect, the permeability and the drug delivery is sometimes limited, and the EPR effect is not actually present in all tumors. For example, in leukemias and lymphomas, you don't see an EPR effect. So you hardly see any role of pegylated liposomal doxorubicin in leukemias or lymphomas. Also in metastatic sites, you don't see a limitation of lymphatic drainage. So that is the reason why the EPR effect is not there at metastatic sites. So that is one of the reasons why the PFS OS is not superior in liposomal doxorubicin. What we have is equal efficacy, but definitely lesser cardiotoxicity. Talking about the FDA approved uses of Lipodox, it is used in ovarian cancer, multiple myeloma, metastatic breast cancer, if there is a higher risk for cardiotoxicity, and AIDS related Kaposi sarcoma. And the extended usage of Lipodox is in cutaneous T cell lymphomas, in soft tissue sarcomas, and also in high grade B cell lymphomas initially, or in salvage also if there is higher risk of cardiotoxicity. Regarding ovarian cancer, there is another talk. They will talk about all these data of Lipodox being a standard of care in platinum-resistant recurrent ovarian cancer, where trial have showed similar efficacy compared to topotecan, gemcitabine, and paclitaxel. It is a standard of care for platinum-resistant recurrent ovarian cancer in combination with bevacizumab, as shown in the Aurelia study. It is a standard of care for platinum-sensitive recurrent ovarian cancer, especially in those patients who are within 6 months to 1 year of recurrence, as by the Calypso and the Gineco data. And even in first-line CA ovary patients, especially patients who have paclitaxel hypersensitivity, the MITO2 data says that the outcomes are similar when you give first-line Lipodox plus carbo. In soft tissue sarcomas, we have evidence from EORTC study that the overall response rate is similar to single agent doxorubicin, and the side effect, the cardiotoxicity, is very less. Also, there is very impressive data in fibromatosis or desmoid tumor, where you have almost 43% partial responses in Lipodox as compared to 39% with anthracyclines. And last year, there was a study presented, a phase 1 study presented in ASCO, which looked at combining Lipodox with ifosfamide in first line in soft tissue sarcomas, and it was found to be feasible. This is again a study in metastatic CA breast, a multi-center study where first line Lipodox was compared with conventional doxorubicin. And what was found that the cardiotoxicity was 9% in doxorubicin, but only 2% in Lipodox, whereas the PFS and OS was similar. Another meta-analysis from ASCO, where patients who had been treated with anthracyclines earlier were re-challenged with pegylated lipodoxorubicin later on, showed that there was no cardiotoxicity, and there were 32% patients who responded to Lipodox challenge, especially if they were challenged beyond 12 months of initial anthracyclines. Another phase 2 study of liposomal doxorubicin concurrent with trastuzumab. So we all know when you give doxorubicin with trastuzumab, there is higher cardiotoxicity. But when you give Lipodox with trastuzumab, this higher cardiotoxicity is not there. And this study showed that when you combine concurrently Lipodox with trastuzumab, the results are, it is feasible, efficacy is equal, and it shows lower cardiotoxicity rates as compared to AC followed by TH. Another case, last case, and a food for thought for everyone. So 71-year-old male, known hypertensive, diabetes, and ischemic heart disease, post stenting, but preserved left ventricular ejection fraction of 60%. Cardiac troponins are normal, and this patient is now diagnosed with DLBCL stage 3BX. Patient has an 8 centimeter mediastinal mass and neck nodes, and it is an IPI intermediate risk. So what should be the treatment for this patient? So if you apply the same cardio-oncology principles, what we understand that this patient is also a high risk for anthracyclines, and RC-DOP, that is replacing the anthracycline H with doxorubicin, liposomal doxorubicin, it is also a recommended option. And phase 2 studies, there are 2 phase 2 studies which were presented in 2008, which say that with this RC-DOP regimen, you have CR rates of 94% in one and 75% in one. And you can look at these NCCN guidelines where it is mentioned that in patients with poor left ventricular ejection fraction, RC-DOP is a recommended regimen. And in patients, even frail patients who are more than 80 years of age with comorbidities, RC-DOP is a recommended regimen. So with this, I conclude my talk, and the take-home messages are: anthracyclines are very effective and essential. We need it, but with all precautions in order to limit the cardiovascular toxicities. Baseline cardiovascular risk assessment is very essential. Primary prevention strategies should be considered for patients who are at high risk of experiencing cardiovascular event. And liposomal doxorubicin effectively decreases cardiotoxicity but retains its efficacy, and it is a very suitable alternative in many situations. With this, I thank you, and I invite you once again to come forward and join our Asian Cardio-Oncology Society. If there are any questions, I'll be happy to address them now. And if later you can contact me on my email or WhatsApp me, and I'll be happy to discuss any issues regarding any cardio-oncology patient. Thank you.
Thank you, Dr. Vivek, for your excellent talk and putting light on cardiotoxicity prevention of anthracycline and use of liposomal doxorubicin. So it's time for maybe one or two couple of quick questions from the audience. So if you have any question, please raise your hand.
Yeah.
I think there is a question there.
Yes, sir, please go.
Thank you for your nice and excellent presentation. I am Brigadier General Mustafil Karim, hemato-oncologist and bone marrow transplant specialist in BMT Center, Dhaka CMH. You have told that due to use of liposomal doxorubicin, there is more mucositis.
Correct, sir.
And infusion reaction. What is the mechanism of it? And due to use of conventional doxorubicin, if we use a long time, prolong the infusion time, then toxicity is less. But in this case, the drug effect will be decreased. And there is after making the solution, you have to infuse the drugs within a limit of time. So how you prolong the time? Thank you.
Yeah. So I think, sir, we are clear on this thing that because of the liposomal nature of it, and it is not able to escape the capillaries, there is higher concentration of liposomal drugs in the capillaries, the small capillaries of mucosa and the skin, and that is the reason for higher mucositis. And we are all experienced, in our CA ovary patients, where patients have a lot of mucositis when you actually give them a lipodox carbo combination. Secondly, sir, as you said correctly, that there is a thought process that doxorubicin, it is a radio, a photosensitive molecule, and if there is prolonged, it is kept a prolonged time, there may be decrease in the efficacy. But again, it is proven beyond doubt that if you prolong the infusion, if you have doubts regarding the photosensitivity of your anthracycline formulation, you can always cover the formulation. And usually, we use a dose adjusted epoch protocol so much, where continuous infusion anthracycline is used for 24 hours, and then again another continuous infusion anthracycline is used. So I think for 24 hours, if you keep the infusion, it does not the product is retained, and for the next 24 hours again you can mix the dose and make the infusion again, and that is how we have been using epoch in all our patients. So continuous infusion, the efficacy is equally good, it is not inferior, and cardiotoxicity is definitely less. Yes, sir.
Maybe we can take one more question. Yes, sir.
I'm Dr. Mofadjil, practicing medical oncology. In the second case that you have shown us lymphoma, you will be treating with RCDOP,
Yes, not R-CHOP, but RC-DOP.
right?
Correct.
Will you prefer in a 2 years old man who is already having some risk factors for cardiotoxicity?
Correct.
RCDOP versus RCEOP.
Correct. So,
Which
sir,
one of these two
Yeah.
you will prefer personally?
yeah. So, sir, if you look at, I will probably in a 80-year-old man, again, I will do a proper cardio-oncology assessment, which I showed you in order to, identify the proper risk. And time and again, sir, I have believed that age is not the, absolute marker. The age is a number, and we need to assess the biological age, the functional age, rather than the actual age, numerical age. And only if you do a proper geriatric evaluation and a proper cardio oncology evaluation, we would be able to know the risks and pros and cons. And it is a recommended regimen. So if it is a fit 80-year-old, I probably will not be worried about using RC-DOP. I have used RC-DOP in a few number of patients, and even in patients who are more than 80 years, I have used R-mini-CHOP. There have been 5 or 6 patients I have treated with R-mini-CHOP where there is a 50% dose of anthracyclines and they have done well. So again, probably we need to come out of this number of age that we assign to our patients. And even at that age, the fit patients, they do deserve the curative intent treatment. They also deserve the best and the efficacious treatment. Of course, I agree, RCEOP is also a recommended regimen, and you can definitely use in frail patients or patients where they have a high risk of cardiotoxicity.
Thank you very much. So,
Yeah, I think one
this is-
last question we'll take from that. And
Uh,
maybe, after the rest of the talks are over, we can continue the discussion.
Thank you, Dr. Vivek, for your very nice presentation. I am Dr. Subroto Mistry, Senior Consultant Cardiologist and Medicine Specialist from Asani Mission Cancer and General Hospital, Mirpur. I have a question about the antidote of doxorubicin. You are using the iron chelating agent, Dex or dexarotuzumab. We know that if we use this chelating agent, the iron content will be low. So how long this can be used with the risks of anemia, formation of anemia, because bone marrow suppression is there because of the use of doxorubicin or chemotherapeutic agents, and you are using iron chelating agent again here. So are there any risks of anemia, and how long this Dex will be used at a case of heart failure patient? Because heart failure is a very acute condition, the patient may be transferred to the CCU.
Yeah.
And there I can use this Dex. How long I can use this, and are there any data about that?
Yeah.
Thank you.
So first of all, we need to understand that dexrazoxane is not an antidote for anthracycline-induced cardiotoxicity or a patient who has already had heart failure. It is a preventive mechanism, and you need to give dexrazoxane concurrently or before every anthracycline infusion that you give in order to prevent cardiotoxicity. And there is enough data that if you give dexrazoxane with every anthracycline dose, then there is absolutely no cardiotoxicity. There is no cumulative or a limited dose of anthracyclines. You can continue giving anthracyclines for, probably unlimited number of cycles. That is what the concept is. Secondly, dexrazoxane is not a very strong iron chelator agent. It is a very weak iron chelating agent. The actual mechanism of action comes by attaching itself to the top 2 beta, and that is the main mechanism of action by which it prevents cardiotoxicity. It is not the actual iron chelation. So definitely, because of doxorubicin, there is no excessive anemia that is observed.
Thank you. So this is a preventive.
Correct, sir. This
measure.
is a preventive. Once the heart failure has already happened, then treating with dexrazoxane will not, prevent heart failure or prevent a cardiovascular event.
But is it well practiced?
So it is
As a preventive.
So I do not have any personal experience of dexrazoxane. In India, what I believe is that at AIMS in the sarcoma clinic, Dr. Samir Rastogi has the highest number of patients where he has used dexrazoxane, around 25, 26 patients with very good efficacy, where he's able to use, doxorubicin beyond 6 cycles that we traditionally use. And he has been able to use it. It is costly and it has to be imported right now. So availability is a big question. So that is the reason why it is not so popular.
Thank you. Thank you.
Thank you.
Okay,
Thank you,
thanks
Dr.
a lot.
Vivek, for your excellent talk. So a big clap for Vivek for such a wonderful talk. Now we'd like to move on to our next talk, which will be a virtual talk. And the topics is very interesting and I think very important for all of us. It's on cardiac evaluation and optimization before starting anti-cancer therapy. And it will be delivered by Dr. Anuprita Daddi. She is the Associate Professor and Consulting Physician, Department of Medicine, Tata Memorial Hospital, Mumbai. So please welcome Dr. Anuprita Daddi for his talk.
Thank you, Akos, and
Is she
thank you,
connected?
Vivek. Can you hear me? Hello, hello.
Yes, we can hear you.
I can.
Yeah. Thank you, Akos. Thank you, organizing committee and Vivek Agarwala for inviting me for this talk. And welcome everyone for today's talk on cardiac evaluation and optimization before starting anti-cancer therapy. So, as you're all aware, cancer and cardiovascular disease often coexist in the same individual with many shared modifiable risk factors. So, focus on distinct diagnostics of cardiovascular disease and cancer with minimal therapeutic overlap and common misperceptions of competing risk and of reduced life expectancy in cancer patient might result in inappropriate deferment of cardiovascular disease screening, risk factor modification, optimal cardiac treatment, and vice versa in this cohort and even in cancer survivors too. Both cardiovascular disease and cancer remain significant public health domain, growing in importantly globally. Despite this threat, the field of cardiology and oncology have been relatively disconnected.
Sorry, your slides are not moving. It's on the first slide.
Oh,
Can you
sorry.
please the screen? It's not going, the slides.
Yeah, you saw? Are you able to see?
Go in screen share
can
mode.
see your slides, but
Yeah, I'm on screen sharing.
You can stop and reshare again. That will be fine.
Yeah, just a second. Sorry for that inconvenience. Just a second. Are you able to see?
not yet.
We are still sharing.
Yeah, it's loading, I guess. There's some network issue here in hospital, I guess. It is coming as your screen share is loading.
Yeah, now it is there.
It's there?
Yeah, I can see the slide. I don't know if it moves
Yeah,
or not.
just. Is it moving?
No, it's not moving.
Slide share.
No, it's not moving.
I can just see the first slide. Your introduction is there, but it is not moving.
I'm just.
Can you please give the slideshow? Slideshow.
Yeah, it's on the slideshow itself.
Ma'am, I think you just need to change the screen.
in the
A lot
sharing.
of suggestions. Now you can see
Yes,
Yeah,
yes.
not as good.
you're able to see the screen.
Yes,
It's moving.
Yes.
yes.
But now when I do this slide scale, it's not coming. Now,
Yeah, I think this way is fine.
Without slide share should be all right, Anuprita.
this is fine.
Yes, yes.
Yes.
Yeah,
Yeah,
now
it's moving now.
Okay.
Yes.
Okay, sorry for that inconvenience again. There's some problem. Okay, so as you are all aware, cancer and cardiovascular disease often coexist in the same individual with many shared modifiable risk factors. So focus on testing diagnostic of cardiovascular disease and cancer with minimal therapeutic overlap and common misperceptions of competing risk and of reduced life expectancy in cancer patient might result in inappropriate deferment of cardiovascular disease screening, risk factor modification, and optimal cardiac treatment, and vice versa in this cohort and even in cancer survivors too. So both cardiovascular disease and cancer remain significantly public health problem growing in importance globally. And despite this threat, the field of cardiology and oncology have been relatively disconnected. So an increased appreciation of interaction between cardiovascular disease and cancer treatment has led to a development of new medical subspecialty, that is cardio-oncology. Now, the goal of the cardio-oncology discipline is to allow patients with cancer to receive the best possible cancer treatment safely by optimizing cardiovascular risk factors and cardiovascular disease before treatment and minimizing the cancer therapy-related cardiotoxicities throughout the entire period of the cancer-directed treatment and even after completion of treatment. In 2022, European Society of Cardiology, along with International Cardio-Oncology Society, published guidelines on cardio-oncology to provide guidance on the definition, diagnosis, treatment, and prevention of cancer therapy-related cardiotoxicity and management of CV disease caused directly or indirectly by cancer. So the aim of the baseline cardiac evaluation and optimization before starting anti-cancer treatment is to have a personalized approach to minimize the cancer therapy-related cardiotoxicity and improve both cancer and CV outcomes. Risk stratification tools are designed to grade the patient with cancer into low grade, moderate grade, high grade, or very high risk of CV complications prior to starting the treatment. Now, this has been published by Heart Failure Association and ICOS, and they're easy to use and implement in oncology and hematological service, while further validation is still needed. Other CV risk calculators are available. A careful clinical history and physical examination lays the foundation for patients who are being planned for cancer-directed treatment, reviewing traditional cardiovascular risk factors and cardiovascular disease. Wherever needed, they should be optimized and controlled and should be ensured that they are properly controlled before and during cancer treatment. For example, simple things like blood sugar level, HbA1c, lipid profile, etc. So cardio-oncology consults are generally a lengthy consults where you have to see, risk assess every cardiovascular risk factor, optimize it, modify the medications, and many more things. Coming to the risk assessment of a patient for cardiac evaluation who is more than 40 years of age or otherwise who have been already high risk of having cardiovascular risk factor or diseases, diabetes mellitus, kidney disease, or any other risk factor which are referred to optimize for cardiovascular risk factor as a treatment goal. People with family history of premature cardiovascular disease, lifestyle factors like smoking, alcohol consumption, sedentary lifestyle, obesity, information of prior history of cancer, cardiotoxic cancer therapies, and their respective doses should be collected. Clinical history of cardiac symptoms should be carefully jotted down. Physical examination, vital signs, and look for systemic potential signs for any undiagnosed cardiovascular disease, such as heart failure, pericardial disease, valvular heart disease, and arrhythmia. Now, most of the patients who will be coming with cancer already have a cardiovascular disease. These patients are potentially at a high or very high risk of future cardiovascular event. They require more comprehensive clinical evaluation of their cardiovascular disease, its severity and prior and current treatment. So depending on the type and severity of cardiovascular disease, additional investigation may be indicated to determine the risk status. For example, stress, dovitamin stress echo, or maybe your cardiac MRI, nuclear perfusion scan, or coronary CT angio. ECG is recommended in all patients starting cancer therapy as a part of their baseline CV risk factor. This is class 1 recommendation. Baseline cardiac serum biomarker measurements are recommended, class 1 recommendation, if the degree of change in the biomarker is to be used to identify subclinical cardiac injury during cancer treatment. Coming to cardiac imaging to identify subclinical cardiovascular disease, degree of pre-existing cardiac comorbidity prior to decision regarding cancer therapy. Transthoracic echocardiography is a preferred imaging technique for baseline risk stratification because it gives you the quantitative assessment of LV, RV function, chamber dilation, LV hypertrophy, regional wall motion abnormality, diastolic function, valvular heart disease, pulmonary artery pressures, and pericardial disease. And mind you, all this will influence a therapeutic decision. Current definition, also the current definition of cancer therapy related cardiotoxicities are based on cardiac dysfunctions are based on reduction of LVF and or relative change in global longitudinal strain. So echocardiography is a class 1 recommendation. 3D echocardiography is recommended. GLS is recommended wherever available. If echocardiography is not available, then cardiac MRI should be considered, and where your echocardiography is not diagnostic, then Muga scan can be considered. Cardiovascular toxicity risk stratification before starting potential cardiotoxic anti-cancer therapy is recommended in all patients with cancer, and this is a class 1 indication. The risk stratification tools are designed to grade the patients with cancer into low grade, moderate grade, high grade, and very high risk of CV complication prior to starting treatment. And these have been published by Heart Failure Association of European Society of Cardiology in collaboration with International Cardio-Oncology Society. So these are as per the clinical history, physical parameters, the risk
एक
factors.
काम करना, एक उर्मिला जी का पहले ECG कर दो.
Hello. So coming to the drug class, depending on the drug class, for example, as Dr. Vivek Agarwala has beautifully mentioned about anthracycline, where you have prior anthracycline exposure, age, young age, female, sex, hypertension, any cardiovascular risk factors, then treatment related, what is the total cumulative dose of anthracycline, and what is the, is it to be given with concomitant HER2 targeted therapy, and the potential cardiovascular risk factor for anthracycline is heart failure, asymptomatic LV systolic dysfunction, ventricular arrhythmia. Similarly, for HER2 history, the age is important, underlying cardiovascular risk factors, cardiovascular disease, prolonged use of HER2 targeted therapy, concomitant use of anthracycline chemotherapy, and the risk factors, the probable cardiovascular toxicity will be heart failure, asymptomatic LV systolic dysfunction. VEGF inhibitors are failure, venous thrombosis, history of hypertension, another used in combination with other cardiotoxic chemotherapy, and the probable cardiotoxic will be hypertension, heart failure, myocardial infarct. BTK inhibitors, again, previous history of atrial fibrillation, male, age more than 65 years, ibrutinib therapy, hypertension, and their toxicities will be hypertension and atrial fibrillation. Again, with immune checkpoint inhibitors, age more than 75 years, previous cardiovascular risk factors, cardiovascular disease, and the probable cardiovascular toxicities will be myocarditis, pericarditis. Also, other baseline cardiovascular risk factors like previous cardiovascular disease, cardiomyopathy, chemotherapy-related cardiac disorder, then valvular heart disease, MI, angina, ECQT prolongation, and all these are to be taken into consideration prior to starting any cardiotoxic chemotherapy. Cardiac imaging, LVEF, biomarkers wherever indicated and needed, and will be monitored subsequently, again, age and CV risk factors. current cardiac treatment, current cancer treatment to be planned, previous exposure of cardiotoxic chemotherapy, and lifestyle risk factors. So these are all graded. So this assessment, along with your clinical history taking assessment, and all this assessment should be considered to stratify cardiovascular toxicity to risk the patient, whether they are low risk, medium risk, high risk. So if there is any no risk factors or one medium factors, low risk, medium risk will have more than 2 to 4 points, and high risk will be any medium risk factors more than 5 points with high risk. Now, why this risk is important? Why you have to stratify this patient before starting any cardiotoxic chemotherapy? Because a very high or high risk patient has to be seen by a multidisciplinary team of cardio-oncology, as an important decision has to be taken whether the treatment versus risk versus benefit of a cancer-directed treatment. Is there any need for further cardiac evaluation? And if any additional cardiac testing is required, will that delay the cancer-directed treatment, and which will affect the disease, underlying disease prognosis? All this has to be taken, and you have to take these decisions without delaying. So hence, a multidisciplinary team where oncologists, cardiologists, cardio-oncologists all sit together on one table under one roof and take this decision for patient without delaying and causing delaying the decision and patient going here and there. Patients at high and moderate risk can benefit from close monitoring, where you would like to decide whether I want to see this patient every week or after each chemo cycle, where I need to strictly manage your CV risk factors. And low risk patient, again, it can be followed up every 3 months, and whenever there is any toxicities coming up or any new CV risk factors develop. So that's why the risk stratification initially is very important, so that once you know the patient and patient starts with cancer-directed treatment, you avoid interruption, further delay, anxiety in the patients. And this is a flow charts which has been provided in guideline, which has HFA, ICOS risk assessments, your physical metabolic. They have given a systematic way of how to evaluate, and whether it's low, if any ECG abnormality or any abnormalities in your CV risk factors has to be optimized wherever needed. In high risk or very high risk, a cardiology consult is to be recommended. So optimal time to consider cardiovascular disease prevention strategy is at the time of cancer diagnosis and at the prior of initiation of cancer treatment while making a cancer treatment choices. Also, communicating the result of cardiotoxicity risk assessment to the patient and other appropriate health worker is class 1 recommendation. Now, it's not only important to educate the patient, but also encourage them to self-monitor basic parameters like pulse, blood sugar levels, BP at home, so that they are aware when to see the physician rather than physician calling them, come after see. So they are aware these parameters are going high, I need to go optimize them. So when I meet the oncologist, there is no postponement or delay of their chemotherapy cycle. So in summary, the principal aim of baseline cardiac evaluation is to receive the best possible cancer treatment, safely minimizing the cancer therapy-related cardiovascular toxicity across the entire course of cancer care as far as possible to avoid interruption in cancer treatment. Optimization of comorbidity should be done in parallel to malignancy workup plan and cancer-directed treatment. With careful cardiac evaluation and optimization before starting and during the cancer therapy, baseline high-risk patient can complete their cancer-directed treatment successfully with close cardiac monitoring. Multimodality cardiac imaging is the era of emerging cancer therapy, so it should be used wherever indicated. Educating people about patients about CV risk factor and cardiovascular disease during and post completion of cancer treatment, along with lifestyle modification with strict control of comorbidity, will avoid cure patients of today to become heart patients of tomorrow. So it's not one size fits all. Hence, a personalized approach is the best option for such cohort of patient. Thank you.
Thank you, Dr. Anuprita, for your excellent talk. Now it's time for a few questions from the audience. Any question?
Thank you. Thank you for your nice presentation, though it is slideshow was not clear. In case of female, pediatric female and fertile female who are more risk for anthracycline. But postmenopausal women and men are same risk. Why? You are the cardiologist, I think. So can you explain, please?
I'm a cardio-oncologist and I didn't get your question. Can you please repeat it? And sorry for my slides, but there was some glitch. I hope you could
Female,
read my slides.
pediatric female in pediatric age or fertile female, adult female in menstruating female who are more anthracycline risk. Cardiotoxicity is more in anthracycline than the postmenopausal woman. Can you explain why?
No, we at Tata Hospital, we have not found such difference. Like if postmenopausal patients are coming at low risk of anthracycline, very young age patients who are receiving anthracycline, and that too, we see, don't know, we can't explain why they are present with cardiotoxicity or chemotherapy-induced cardiotoxicity, but there is no difference. In fact, we found postmenopausal women, because of the underlying comorbidities, lifestyle, indisciplined lifestyle, uncontrolled, they are more prone for cardiotoxic effect is what our clinical experience is. So I'm sorry, I'm not aware of this, that they are doing well and maybe because the pediatric group, we are into adults, so maybe the pediatric who must be referred, must be going to pediatric cardiologist. But in our setup, we have not seen such difference.
Any question? Vivek, would you like to add anything with this presentation?
Yeah, I think in one of my slides, I showed that, the cardiotoxicity with anthracycline is additive and the total number of cardiomyocytes that you have is fixed. So if you are, if there is a very young patient, then they usually, the number of cardiomyocytes start declining very early and they don't have the spurge in cardiomyocytes that happens at around 18 years of age. So young people, again, they're bound to have more incidence of late cardiotoxic effects because of introduction of cardiotoxicity early in their life. But I agree with Dr. Anuprita that postmenopausal females, especially if they are more than 65 years of age or 60 years of age, they are probably, they don't have the cardioprotective effects of estrogen. And they are likely to have more cardiotoxicity or cardiac dysfunction as compared to younger women.
If there is no more question, we can move on to our next session. Thank you, Dr. Anuprita, for your talk. A big clap for Dr. Anuprita.
Thank you so much. And sorry for that inconvenience. Thank you.
So now we have our second virtual talk, and it is also very important. It's on preventing cardiotoxicity after radiotherapy. Will be presented by Dr. Sapna Nangia. She is the director, head and neck, breast cancer. She is a senior consultant of radiation oncology at Apollo Proton Cancer Center, Chennai. Please welcome Dr. Sapna Nangia. Can you hear us?
Yeah. Good evening, everyone. It's indeed a pleasure to be here. It's a pleasure to meet you again, Arunangshu, virtually this time. And just last month, I was in Dhaka, and it was really, I'm really delighted to be back discussing, though virtually, discussing about various cardioprotective strategies that we may use when treating patients who are at risk. I will begin by sharing my screen. At the outset, I'd like to thank the organizers of the meeting, and I'd also like to thank Dr. Vivek Agarwala for having invited me, as well as the Bangladesh Society, Cardio-Oncology Society for having invited me. Please let me know if you can see my screen.
Yes, we can. Thank you.
Okay, so I am going to discuss preventing cardiotoxicity after radiotherapy, and specifically I shall focus on the role of proton therapy in breast and lung cancer. I bring you greetings from the Apollo Proton Cancer Center, which is the first proton therapy center in South Asia. And we have now been functioning for more than nearly 5 years and have treated more than 1,200 patients drawn from various parts of the world. Why are we discussing cardiotoxicity? Of course, there have been excellent talks before mine with Dr. Agarwala highlighting the fact that improved outcomes of treatment, whether it be breast cancer, whether it be lung cancer, we are looking at increased or better outcomes of treatment. When we talk about better outcomes of treatment, even in the community setting from South Asia, we see that patients who are even TNBC or who are stage 3, they have a 5-year overall survival in the range of 70% and more, which is why we are required to pay attention to issues that arise amongst survivors. These issues are issues like fertility management, lymphedema prevention, handling chemobrain, as well as cardiotoxicity. We want our patients to have fruitful lives. As has been discussed, besides adriamycin, of course, for which many solutions have been suggested, there are other cardiotoxic agents that patients who undergo breast radiation receive, such as docetaxel, which is associated with the risk of congestive heart failure. Trastuzumab, of course, is well recognized, and even letrozole is associated with a doubling of cardiac effects. In this background, we must see that radiation also can result in a higher risk of having cardiac problems. The landmark study in this was by Darby et al. In the year 2013. What did she tell us? This study looked at a population-based case control study and looked at the risk of major coronary events, myocardial infarction, coronary revascularization, and death from ischemic heart disease. What was noted was that if patients received what is the usual sort of dose that patients would receive if we were not paying attention to cardiac dose, which is 5 to 9 gray to the heart, there would be a 40% increased risk of having a cardiac problem. If we brought this dose to 2 to 4 gray, that risk became from 40 to 30. If the dose received was 2 gray and less, that risk was 10% over baseline. What is important to note, and the second arrow is pointing towards it, is that it's not a late effect. It is an effect that can occur even in the first 4 years after treatment. In fact, the risk within the first 10 years was noted to be 15% higher, not 7.4%, but 15% higher for every gray increase in risk to the heart. Now, who are these women who have a high baseline risk, where a 30-40% jump would mean a lot? The same list that has been mentioned by Dr. Vivek and Dr. Anuprita. Women who are diabetic, obese, hypertensive, women who are smokers, and in this, I would like to add an additional point. Women who have left-sided breast cancer and women who are receiving adriamycin, Herceptin, etc. So these are women who are at higher risk of having a cardiac problem. But is it only women who have left-sided breast cancer who have a higher risk of having cardiac problems? No. If we look at the Swedish breast cancer cohort study, which was conducted in the years 1970 to 2003, it was noted that women who had not been irradiated, about 42% of them would have a right coronary artery stenosis. But right-sided breast cancer patients who also received internal mammary node irradiation, if they needed to go on angiogram, then the risk of noting a right coronary artery disease was as much as more than 70%. So yes, even certain right-sided breast cancer patients, the ones who are requiring right-sided, the ones who are requiring internal mammary node irradiation, because of the disease being present in the medial quadrant, they were also at risk of having cardiac problems. Is it something that happened in the past and is not relevant today? No. We look at a contemporary group that has published its data about 2 years ago. This is Abraham et al., who have published from Canada. And what we note is that even in a contemporary group of breast cancer patients, about 17% of patients, left-sided breast cancer patients, may have any cardiac event. We are not talking only about myocardial infarction. We are talking about the arrhythmias, the valvular heart disease, the pericardial effusion, etc. About 17% of them would have cardiac disease. And another study, very recent, from the William Beaumont Hospital has told us that the threshold for having any cardiac problem, according to them, is only 1.55 gray. Now, in this background, we also have to note the fact that people in South Asia have a higher risk of having any cardiac problem. And for this, we have been using the Q-risk calculator. The Q-risk calculator looks at the risk, 10-year risk as well as lifetime risk of people who live in the United Kingdom, but they have certain separate risk assessment tools for Indian and Bangladeshi patients. So what we are seeing here is that for a woman who is 60 years old and who has a normal BMI, a white lady would have a 4.5% risk of having a stroke or a heart attack in the next 10 years. However, if she was Indian, that risk would be 6%. But if she was obese, diabetic, and hypertensive, if she was white, she would have a 13.9% risk, a big jump from 4.5. If she was Indian, she would have an 18% risk. If she was Bangladeshi, she would have a 19% risk. This is to underline the fact that we South Asians have a higher risk of having cardiovascular disease, something that needs to be paid attention to when we are looking at cardiac assessment and offering treatments which will reduce cardiotoxicity. One of the most commonly used techniques is deep inspiratory breath hold, where the patient holds her breath in deep inspiration while we are doing the routine X-ray based radiation. Holding the breath in deep inspiration makes the heart tubular, takes the breast or the chest wall away from the heart, and that reduces cardiac dose. This is usually done by using proprietary techniques such as ABC by Electa, RPM by Varian, and certain other vendors who offer techniques which reduce the dose to the heart. However, in low and middle income group countries, it may not always be possible for, we may not have machines where these proprietary techniques may be available. And this is something that I have developed with my team. This is a frame by which we can manually deliver deep inspiratory breath hold. So we can give a feedback to the patient, and she senses when she has reached optimal deep inspiration, and then manually the machine is switched on and then switched off. It has to be done very, very carefully, of course. But what we have noted is that by using this sort of technique, we are able to replicate the results that are being used with other proprietary techniques, which means about a 30 to 35%, 35 to 40% reduction in the dose being received by the heart, and the dose being received by the left anterior descending, as well as the dose being received by the ventricle. This brings me to proton therapy, which at present is the best available technique to reduce cardiac dose. What are protons? Protons are charged particles, which, if this is the blue, is representing the photon, the white bar is the tumor. Photons, X-rays will travel through and deliver their energy even beyond the tumor. Protons will stop at the tumor and not go beyond. And that allows us to restrict dose to various structures. In this case, we are interested in the cardiac dose. So there are 3 generations of proton therapy machines. At present in India, what we have is the latest generation of the pencil beam scanning technique, which allows us to treat the tumor layer by layer using a 3 millimeter proton beam. Now, how is it effective, or what is its role in proton therapy in breast cancer or in reducing cardiac dose? So this is a comparison. The green that you see are DIBH X-ray based treatments, and the turquoise that you see is the proton dose. What we see is, when we have looked at the two cohorts of patients treated with the standard treatment versus what proton can do, we see that there is a significant reduction in the dose being received by the heart by the left anterior descending. What is significant? 76% reduction, 67% reduction, 54% reduction in the mean dose being received by the left anterior descending. So this is what proton therapy allows us to do, and this becomes valuable in patients who have a high risk of having radiation-induced cardiac disease, such as having left-sided breast cancer, or requiring internal mammary node irradiation, or having the background of diabetes, obesity, and hypertension. This is a pictorial representation of a comparison of a photon with a proton plan. This is an axial CT scan. It is showing you the right breast and the left breast. The left breast is being treated. What we need to treat is what the desirable dose is in yellow. And everything that is not yellow, all the other colors that you see, are undesirable dose. So the proton, the undesirable dose, is not going to the heart and the left anterior descending. It's not going to the opposite breast, the lung, or the flank. While in photons, it will go to the heart. And the quantum difference is very, very significant, as you can see. Is this some new treatment? No. Data has been presented from many centers all over the world. One of the longest data follow-up is from the Mass General Hospital, as respectable as they come, with a local regional failure rate of only 1.5% and an overall survival of 91% with a follow-up of more than 7 years. We ourselves have published our data of the first 20 patients we have treated. Since then, we have treated double this number, and we have published this in the Radiation Oncology Journal. These patients are being registered on a registry that we call the HyPro-B. This is a 15-fraction schedule, both for chest wall as well as for patients requiring whole breast irradiation, including boost. And these are representations of various treatments. On the top panel, you see 2 intact breasts, 1 with a boost, which is represented in red. On the bottom panels, you're seeing 2 chest wall treatments, both receiving internal mammary node irradiation. And as you can see, in all of these, less than 10 gray, the 10 gray is the green one, even that is not coming anywhere near the lungs and the heart. In special situations like pectus excavatum, we've had patients who have traveled from other parts of the world, because in pectus excavatum, because of the anatomy, the heart is shifted under the breast, and the dose that would be received would be very high, and we are able to reduce that, as you can see. So this light green that you're seeing spilling all over the heart does not happen when we use protons. Similarly, if patients have bilateral breast cancer, they are at a higher risk of cardiac disease because of the dose being received both from the right side as well as the left side. And proton therapy allows us to reduce that dose. As you can see, both sides of the one side, intact breast, opposite side, a chest wall is being treated, as you can see on the panel on this side. And we are able to contain the dose to the heart. I move next to thoracic malignancies. Now, in thoracic malignancies such as non-small cell lung cancer, esophageal cancer, thymoma, and mediastinal lymphomas, again, the cardiotoxic effects of radiotherapy are important. In mediastinal lymphomas, young children being treated for mediastinal lymphomas may manifest cardiac disease even 20 to 30 years later. In thymoma, because of the impact of proton therapy, proton therapy has even been included in the NCCN guidelines. But to go into a slightly greater detail, there are various studies which have looked at various dose impacts, whether it is the dose to the superior vena cava, the dose to the right atrium, RCA, the bilateral ventricle, etc. This has been published in a detailed article by Banfield et al. In the Journal of Thoracic Oncology, wherein the dose being received by various parameters has been correlated either with better outcomes, or with toxicity. Specifically in lung cancer, we know that the heart V5, the volume receiving 5 gray and the volume receiving 30 gray are associated with the overall survival, and that is an independent prognostic factor. Not just that, if we look at cardiac events, when the mean heart dose is less than 10 gray, the cardiac events are 4%. And if the mean heart dose is more than 20 gray, the cardiac events may go up to even 41%. These is from various dose escalation trials. And naturally, the risk of both myocardial infarction, pericardial effusion, etc., increases, and approximately half of these events may occur very early within the first 2 years. There is a randomized trial which looked at proton versus photon. However, this was a flawed trial, and for reasons of so let me just explain that this was a trial that used an older proton therapy technique. And when a sub-analysis was done in this trial, which did not actually show a reduction in toxicity, the toxicity that was being studied was radiation pneumonitis. But when finally a subgroup analysis was done and we looked at the toxicity to the heart, when we compared the older proton with the newer proton, we found that there was a significant difference in the grade 3 toxicity, even within the proton domain, between the passive scattering, which is the earlier technique, versus the newer technique, which is the intensity modulated proton therapy. And what is the reduction? As you can see, with passive scattering proton therapy, there was a 14% risk of having grade 3 cardiac toxicity. But with IMPT, that is the modern radiation technique that I've discussed with you, it came down to 0%. So this is a slide that has been kindly shared by my thoracic oncology colleague, Dr. Srinivas Chilkuri. What we see here is a patient in whom the radiation parameters to the lung and to the heart were so bad that the planned dose was prohibitive. Yeah, the safe threshold for V20 for lung is 30%. But it was achieving 36%. The threshold safe dose, as I've already specified, is less than 10 gray. In this case, it was 30 gray. What we needed to treat was the red here, and everything else is extra. This patient had mediastinal and opposite mediastinal lymph nodes also. And then when we compare the proton plan with the photon plan, as you can see, what we need to treat is red. And all the extra colors that you're seeing outside of that, the orange, the purple, the blue, and the green, all represent unnecessary radiation doses, radiation spill on the heart as well as on the lungs. And what we can see here is that proton therapy has allowed us to limit the dose to these structures. And what is the dose that we have been able to achieve? From the mean heart dose from 29.8, nearly 30 gray, has come down to 7.2 gray. And that is the gain that proton therapy has allowed us to do in this patient. And we were actually able to treat this patient. I'll close with this randomized trial. This is a phase 2 randomized trial of a comparison of proton beam therapy versus intensity modulated radiation therapy for locally advanced esophageal cancer. This randomized trial has been conducted in the University of Pennsylvania. 174 patients have been randomized to receive either proton therapy or intensity modulated radiotherapy. Half the number of patients have undergone surgery after that, and the other half have been treated with definitive chemoradiation. What we are seeing here, it's a very novel concept of total toxicity burden. And when we look here in the on this colored part of the graph, what we are seeing is that IMRT, this is the red bar that you can see, these patients have, toxicity as we go along in the treatment. They are developing toxicity. This is indicating the total toxicity burden of 300, the scoring system that they have done. And as time has gone by, they have gone on to receive, they have gone on to have toxicity. However, the proton therapy plan, which is the lower down, we are not seeing any yellow or red or orange, indicating that these patients did not have a high toxicity burden. But today we are interested specifically in looking at cardiac doses. When we look at cardiac doses, we find cardiac toxicity, we find that IMRT associated with all the cardiotoxicity major numbers that you're seeing, whether it is atrial fibrillation, myocardial infarction, or asymptomatic pericardial effusion, that is larger in the IMRT data group versus the proton beam therapy group. In proton beam therapy, there is 1 atrial fibrillation versus 5 in the IMRT group. There are 2 pericardial effusions asymptomatic versus 6, and no myocardial infarction versus 1. Similarly, in the post-op, you can see atrial fibrillation, 2 patients versus 7. The cardiotoxicity being significantly less in the proton therapy group in this randomized trial. So in conclusion, I would like to say that attention to cardiotoxic impact of radiation is important when treating breast thoracic malignancies with radiation. Deep inspiratory breath hold allows the reduction of cardiac dose for breast cancer, and its use is to be encouraged as far as possible. And the best reduction in heart and cardiac substructure dose is possible with proton therapy. I would like to acknowledge the team at the Proton Therapy Center, my colleagues in radiation oncology, physics, and radiation therapy. And I thank you for your attention.
Thank you, Dr. Sapna. Now it's time for a few questions from the audience. Vivek.
Dr. Sapna, in the case that I presented, in last, there was a case of high-grade diffuse large B-cell lymphoma with a large 8 centimeter mediastinal mass. Now, in case traditionally, when you have large disease sites, you tend to give radiotherapy also in lymphomas, whether it's Hodgkin's or non-Hodgkin's. But in case, in the current era, when you look at cardiotoxicity aspect of the treatment, and with systemic therapy, patients already receiving anthracyclines, and when they have a complete metabolic response, would you still want to give the mediastinal irradiation, or would you avoid it?
So firstly, let me just specify that I don't treat lymphomas. My basic area of focus is on head and neck, breast, gynecological, and skull-based malignancies. I have, of course, treated lymphomas in the past. Now they fall in the domain of my thoracic oncology colleague, Dr. Srinivas Chilkuri. Having said that, yes, I do believe that radiation continues to have a role in the treatment of non-Hodgkin's lymphomas, and very often it is a considered decision. In many situations, we would be looking at, especially in Hodgkin's or pediatrics, we would be looking at dose de-escalation. We are treating these children to smaller and smaller doses. In non-Hodgkin's lymphomas also, we would be more towards the 30 gray rather than the 36 gray, wherever there is a range. But having said that, no, I do believe that proton therapy allows us to reduce the toxicity of treatment. And that is one group where we must consider it, because these are patients who are actually going to have long survivals. So we should be looking at the best possible treatment with the least possible toxicity.
Next question.
Next question.
Thank you, Dr. Sapna. I am Dr. Subroto Mistry, Senior Consultant Cardiologist. I have a very simple question, it may be a very foolish question maybe, that you are eradicating the internal mammary artery in case of left breast lady. So if she needed anytime bypass surgery, CABG, then internal mammary artery, you know, there is a very important artery together with the saphenous vein. So if you can spare that artery, that will be beneficial for her if she may go for CABG in her next life. So, is it possible to
so that's a very
spare the internal mammary artery?
So that's a very interesting question, Dr. Subroto, and I thank you for asking me this and making us, kind of what should I say, rack our brains or think. But let me just explain that internal mammary node irradiation has been shown to improve survival for a specific group of patients. So all women who have medial quadrant or central quadrant tumors, or who have a high lymph nodal burden in the axilla, adding internal mammary node irradiation actually improves their survival. So, and when we treat internal mammary nodes, we actually encircle, or, the radiation is going along the internal mammary vessels. So we would not be able to spare or, keep it in reserve for further, bypass. I guess it would have to be the other side internal mammary artery, which would not be irradiated actually. Or it could be as the earlier way, times we used to use the saphenous, I think.
Thank you.
Thank you for your nice presentation. Can I ask a question?
Surely.
Okay. Thank you for your nice presentation. Patient with mediastinal lymphoma, only before doing autologous bone marrow transplantation, patient with valvular heart disease. So in this case, left-sided heart is more prone to develop radiation-induced toxicity, mainly aortic and mitral valve. So in this case, when we do PET scan, all side of the lymphoma cleared by chemotherapy, but mediastinal side is involved. In this case, such case with the valvular disease, how can we prevent radiation-induced protection from valvular heart disease patient before doing autologous bone marrow transplantation?
So I think it's a, particular situation that you're talking about, and it would really be a situation of actually doing the radiation planning to see whether, the dose to the valves can be restricted. So I don't think there would be a generic answer to this. There would have to be a specific radiation plan created for the patient. And there can be situations, where a radiation plan may be prohibitive because the toxicity may be more. That can happen in certain situations. It would have to be an individualized treatment plan.
What is the cost of conventional radiotherapy versus proton therapy? Because proton therapy is not available in Bangladesh. Can you give idea?
So, conventional radiotherapy costs, so if we look at the range of proton therapy costs, it may vary from approximately 2 times, double the cost of conventional radiation, especially if we are doing limited number of fractions, such as a 5-fraction treatment like we do for prostate or lung. That is generally double the cost of normal radiation. However, it may go up to approximately even 10 times in certain situations. For breast cancer, it is generally approximately 4 times the cost of normal radiation at our hospital.
if there is no question, I want to ask one question to both the speaker. For a left-sided breast cancer, who is HER2 positive, so she will be treated by radiation, anthracyclines, and HER2 directed therapy like Trastuzumab. So after a certain period of time, how we will be able to understand which one is responsible? I know this is not a very scientific question, but there are so many compounding factors for a breast cancer patient receiving so many treatment, radiation, anthracycline, and anti-HER2. So what is the median time when we expect the toxicity can happen in terms of radiation and chemo? And which one is responsible? Is there any way to understand what is the most important compounding factor for this cardiotoxicity for a particular woman?
Yeah.
Vivek, you first.
Yeah, I think regarding the timing question, I think it all depends upon multiple factors, which will include traditional risk factors, lifestyle, diet, and so on and so forth. So it is difficult to predict a time. But then there are risk calculators, as Dr. Nangia also showed, as well as the risk stratification guidelines by ICOS. That also shows that the probability of risk, what is it, whether it is 10% in 10 years or 20% in 10 years. So that is the way to predict. Regarding predicting what is the actual cause among the different agents, so at least we know it is not because of anti-HER2 therapy, because they are reversible. They don't cause permanent damage. And radiation induced damage is more towards a fibrosing kind of so suppose if you are doing an autopsy, or suppose you are doing a myocardial biopsy of a patient who has cardiotoxicity, then there will be different pathological features that will get in a radiation induced injury vis-a-vis a different picture that you are going to get in an anthracycline induced injury. And nowadays, with the help of cardiac biomarkers, as well as good quality and a cardiac MRI, now I think it is definitely we can differentiate whether it is a radiation predominant or an anthracycline predominant. But we must know that all are contributory, and it cannot be taken into single, because we already know that how the risks are increased by each and every treatment.
I think there is no more questions, so we'd like to move on to our next part. Thank you, Dr. Sapna, for your excellent talk.
Thank you
Big
very
clap
much.
for Sapna.
Thank you.
So our third and the last talk is on hypertension management in cancer. Will be presented by Dr. Amit Kumar, who is a senior consultant and medical oncologist and hemato-oncologist at Medanta, Patna. Dr. Amit Kumar, over to you.
Yeah, good evening, everyone, and greetings from Patna. And thanks to Dr. Purvesh and Dr. Vivek for organizing such a meeting, an important feast, I'll say, for the important role of cardiotoxicity, especially for oncological patients. So the role assigned to me is about the role of hypertension management, and that's the most important thing. So most patient of which present to us may having some hypertension. And if we see this hypertension, so in onco-hypertension, we say there could be either a pre-existing cardiovascular risk factor the patient may be having, that is due to aging, diabetic, smoking, or physical inactivity or obesity, anything. Or it could be due to the anti-cancer therapy which we are giving to these patients. Or it could be indirectly due to the hit of the cancer treatment also we are giving to the patient, like deconditioning, weight gain, pain, stress, anxiety. So the multifactorial things come in play for this onco-hypertension. And the hypertension could further lead to, as you know, cardiotoxicity, nephrotoxicity, or vascular toxicity, thus increasing the risk for CVD and mortality in this group of patients. So what we see about the incidence and mechanism of these hypertensions, the prevalence is something around 38%. Means 38% of the onco patients is having hypertension. And depending on the different therapies which we are giving, for proteasome inhibitors, it may go to 10 to 32%, with calcineurin inhibitors 30 to 60%. And the VGF, that is the most important inhibitors which we are giving, it may go up to 20 to 90% in these group of patients. Apart from other TKIs like Bruton TKI, 71%, the platinum-based therapies, which the chemotherapy which we give, they may cause hypertension in 53% of the patients, and other alkylating agent 36%. So means most of the drugs are causing this hypertension in these patients. And the mechanism, it could be due to increased capillary rarefaction, increased mitochondrial dysfunction in this group of patients. Nephrotoxicity is one of the most important things which we have to take care. There's a decreased angiogenesis which may happen, which may lead and decreased production of nitric oxide, along with increased endothelin and increased sympathetic outflow, which causes this hypertension. So how do we going to define the hypertension in the patients with cancer, especially? So they are all the guidelines that we say from ICOS or the CTCA or American Cardiology. So all of them mostly have taken the cutoff less than 130 by 180 to be normal, and above that we say the CTCA criteria. The grade 1 hypertension comes in between 120 to 139, and with the diastolic is 80 to 89. And thereafter grade 2 going to 140 to 159 and diastolic to 90 by 99. The important thing where we have to take concern is about the grade 3 or more toxicities. So anything more than 160 by 100 by NCI goes for, I'll say grade 3. By European Society also seems the same. The systolic, they take the grade 3 as 180 by 110. So we have to, the different guidelines were different, but what we follow is mostly the CTCA guideline, which takes 160 by 100 as a grade 3 toxicities in most cases. So diagnosing cancer, hypertension is self. Either you can do by a self BP monitoring at home with automated arm curve that you use, 24-hour ambulatory BP monitoring in the hospitals, which happens, it can be done, and remote patient monitoring programs, which are still not present in the developing countries. Even in India, we don't have like these programs, but we have to go to the patients and take the BP at different times. It might be a 1 or 2 recordings, and then we confirm that. So the major challenges in this treating hypertension. So as we already discussed, it may be due to the effect of antineoplastic therapies. It could be a paraneoplastic syndrome or a pre-existing hypertension, or effect of non-antineoplastic drugs can cause. But there are multiple drug interactions which may occur. The non-compliance on the part of the patient which affects, intolerance to the medications because of the side effect of cancer treatment may lead to this, or the labile nature of the hypertension. So sometimes you may say the patient may have hypertension, other time hypotension. So that may too happen due to the sympathetic stimulation in these patients. We also use certain non-neoplastic drugs such as the steroids, erythropoietin. So this may add to that. And there are few pharmacogenetic interactions between the cancer treatment and hypertension related genes. So all these are factors which causes a challenge in managing hypertension, I'll say. So before doing the workup for these hypertension, so one should also know that hypertension is a risk factor for RCC, breast and prostate. So there are data which suggests that hypertension may cause RCC and may have some role in the causative analysis showing both breast and prostate. So we have to take a pre-existing history. So that is the most important thing, that you have to take a detailed history and assessment of past drug intolerance, interactions, do an ECG and echo. So these are the minimum things which we have to do. Then you have to rule out also secondary hypertension in this by doing the renin, aldosterone, serum metanephrines, catecholamines, cortisol, ESR-induced proteins. But this we always don't do if only we are suspecting a secondary hypertension in an young chap, then you may go for this. The other things are renal artery Doppler you have to take. And you have to look up the patient examination by excluding sleep apnea, to take the dietary assessment of salt intake. And if the patient is using any stimulants, drugs, alcohol, and any past history of, of smoking, diabetes, chronic kidney disease, physical inactivity, or any obesity, oxidative stress, inflammation. So history taking is one of the most important thing, and thereafter the clinical examination of the patient, which may help you to further assess the patient. And in some tumors, it could be just a paraneoplastic manifestation, as in RCC, though it is a causative thing, but it is also a paraneoplastic syndrome, where it may be due to the vasoactive peptides or urotensin 2, which may affect this. And also in SCC, carcinoid, or desmosplastic small round cell tumor, it could be a paraneoplastic syndrome. So one have to be aware of these conditions. So as already done about the mechanism of hypertension, so the important thing is about the VEGF, which takes the pathway. So any VEGF pathway inhibitor is causing it. So apart from that, the calcineurin inhibitor, PI3K inhibitors, the platinum-based compounds, so all through different mechanisms like increasing rarefaction, increasing sympathetic outflow, increasing endothelin, or increasing mitochondrial dysfunction and decreasing angiogenesis may lead to an increased reactive oxygen species and increase intracellular calcium, and thereby decreasing the nitric oxide level, resulting in hypertension. So all drugs, if we see the BRAF, MEK inhibitors or proteasome, so all that are different sites causing this hypertension. So one have to be cautious about the mechanism of the hypertension with the different drugs you are using, we may say. And most of them goes to then to the VGF pathway, that is a RAS, RAF, MEK, ERK pathway, or the PI3K, PDK, KTM, TOR pathway, which affects the endothelial cell survival and proliferation with decreasing nitric oxide synthesis and vascular relaxation. So that's the most important pathway which happens in this. So important is about the drug-drug interaction. So if you say the metoprolol we use beta blockers, so this level of the metoprolol may be raised by TKI such as imatinib and gefitinib. So one have to be cautious when you are using metoprolol with imatinib and gefitinib. TKI such as ceritinib and crizotinib may cause an additional bradycardia with all the beta blockers. So, and there's a potentiation of QTC prolongation with beta blocker and all TKIs that may prolong the QT. So you have to be taken careful. If you are using a carvedilol, it may going to interact with afatinib and venetoclax, and it should be avoided with that. So drug interaction, I'll say, is always to be checked before prescribing any of the drugs, especially with the TKIs, you may have a different interaction. For calcium channel blocker, it is always said that you have to avoid diltiazem, verapamil, and feldopen because they may increase the plasma level of most of the TKIs. And verapamil further decreases excretion of doxorubicin, paclitaxel, inotecan, and so it may cause more of a cardiotoxicity from these drugs. For the felodipine, it may also worsen sorafenib or hypertension via CYP3A4 pathway. You have also, if you are using adalasib, you have to avoid amlodipine in this group of patients because it increases the amlodipine level. And it may also, it says that amlodipine may increase the avoid amlodipine in hepatotoxicity from the TKIs. So ACE inhibitor, as we know, it may cause increased angioedema with mTOR inhibitors. So with everolimus, ACE inhibitors, you have to be cautious. Thiazide diuretics, it may potentiate the myelosuppression of the CMF-like regimes. Loop diuretics, that is the most important when we are giving cisplatin. We know the ototoxicity and nephrotoxicity of the cisplatin. Earlier, you used to give drugs like furosemide to all the patients with cisplatin for, but it has to be stopped. So in our clinical practice, because the nephrotoxicity and ototoxicity effects are increased with that, so loop diuretics has not to be given along with cisplatin. And it may further also cause electrolyte imbalance, as we know, even with cisplatin, it may cause most of the patients may have a hypokalemia and hypomagnesemia, which we correct this, causing worsening QT prolongation with these TKIs. And further, furosemide may also increase methotrexate toxicity. So one have to be concerned about that. Regarding the potassium-sparing diuretics, the mineralocorticoid receptor antagonists such as spironolactone, eplerenone may have some role with co-administration with anti-androgen drugs. May be associated with progression of prostate cancer. There are few data, but still that's the most important reason for that. So the next question comes, when to treat this group of patients. So the recommendation for treatment for the threshold for hypertension also varies around the general status of the patient. If we say if the patient is a cancer survivor, then they may be treated as a normal individual, and you may start treatment when the blood pressure systolic goes to 130 to 134. You may start, but surely more than 135, the treatment is there. But if it is a curable cancer during treatment period, the threshold increases to 135 by 39. Of the systolic blood pressure. But depending on the prognosis, if the survival is more than 3 years, then again your threshold increases to something to start treatment is 140 to, if the systolic BP is more than 140, then you may go for, if the survival is 1 to 3 years, then you may further wait for this group of patients with a slightly higher blood pressure side. And if it is less than 1 year, surely around 160, 140 to 159, in that condition, you may start treatment in this group of patients. So considering the survival of the patient, the treatment for the hypertension also varies, and this is all based on the European Society of Cardiology guidelines. So how we treat these group of patients? So the treatment, as we say, the BP target during cancer therapy should be less than 140 by 90. That is the class 1 recommendation. And if may also go to less than 130 by 80 if it is well tolerated in those group of patients. So in selected patients, so with the metastatic cancer, you can wait up to 140 by 60 systolic and diastolic till 90 by 100. You may also hold treatment. And depending on the initial blood pressure, if the BP is more than 160 by more than 100, in that case, either you have to use a combination of ACE inhibitor or ARB along with calcium channel blockers, that is the dihydropyridine ones. Or if it is less than 160 by 100, in that case, a single agent you have to use, either ACE inhibitor or ARB, and thereafter the dihydropyridine calcium channel blocker as a second line therapy. And if the patient is found to be progressing and either the ACE inhibitors or the calcium channel, in that case, that is labeled as a resistant hypertension, though you then may go for the third lines as beta blockers or spironolactone or the nitrates or hydralazine. So this goal is also, there's other flow chart says if there's a proteinuria present, surely in those group of patients, you're going to consider ACE inhibitor or ARB inhibitors and going to the maximum tolerable dose. And thereafter, even if the blood pressure is not controlled, then the second line is dihydropyridine calcium channel. If not, you may start up with the dihydropyridine calcium channel blockers and thereafter going to the ACE inhibitors. And thereafter, you may go into the diuretics in the third line, and after that, the mineralocorticoid receptor antagonist, if there is no contraindication to that, that is nebuliol or carvedilol after that. And lastly, you may go in this group of patients with the nitrates or vasodilator or central alpha agonist. So this chart clearly shows how to treat the patients with hypertension in this subset. The other things before starting these drugs, you have to take the consideration the comorbidities the patient is having. If the patient is having a diabetes with nephropathy, proteinuria, surely ACE inhibitor or ARB or SGLT2 T2 inhibitors can be done. If the patient is having a congestive heart failure to be starting with, or with a left ventricular systolic dysfunction, ACE inhibitors or ARB are the first line. Thereafter, SGLT2 inhibitors, then beta blockers, and then the mineralocorticoid receptor antagonist and loop diuretics. With coronary artery disease, beta blockers comes the first hand, then after ACE inhibitors and nitrates. Arrhythmias, beta blocker. Resistant hypertension, mineralocorticoid receptor antagonist and nitrates or hydralazine. And those with elderly, that is those with isolated systolic hypertension. So the calcium channel blockers may be the first line to be preferred in this group of patients. So if we see the different drugs which we are using in the anti-cancer therapy, so if for the most of the drugs, the first line treatment goes to be the ACE inhibitor or the calcium channel blocker, except for few like those with we'll say with androgen synthesis inhibitors like abiraterone. You may go with eplerenone or diuretic in this subset of patient. For enzalutamide, if you are giving, in that case, calcium channel blocker is the first preferred over ACE inhibitors in this subset of the patient. For PARP inhibitors, niraparib, if we are using basically a beta blocker like nebuliol or carvedilol is preferred over ACE inhibitors in this subsets. For cyclosporine tacrolimus, post-transplant, if you are using, calcium channel blocker comes first. After that, diuretics. If it is susceptible due to steroids, that might be a mineralocorticoid receptor antagonist or diuretics in these patients you may take in consideration. But in most of other cases, that is the ACE inhibitors comes first and thereafter the calcium channel blockers, which you have to take. So it all depends upon the mechanism of action, how these drugs are causing the hypertension you may target in that way. The other important thing that you have to share with the patient is about the lifestyle modification. So limiting sodium intake with consideration for risk of hypovolemia, that is the important thing you have to take care. NSAID, if the patient is using, you have to find out if the patient is using caffeine or alcohol use, that has to be decreased. Increasing the physical activity on the patient and potassium intake is important. And clinicians should address the potential role of any inadequate pain control, because pain is a thing which is the patient in the metastatic sense is having a pain and which may cause an hypertension. So it should be adequately controlled along with concomitant therapies that make exacerbate hypertension, such as ESAs and corticosteroids. You have to curtail that. And if any comorbidities like sleep apnea or anything, you have to work up for that. The other thing is important that when you stop the treatment, anti-cancer therapy, then that case, you have also to consider the dose reduction. You have to decrease the dose of the antihypertensive or even drug discontinuation after the drug holiday. If there is a severe hypertension, that is, it is more than 180 by 110, in that case, the competing cancer treatment it has to be discussed, I'll say, with a multidisciplinary team. And any cancer-directed therapy should be deferred initially and temporarily withheld till the blood pressure is controlled below 160 by 100 in this case of patients. And in patient with resistant cancer, therapy related to hypertension, spironolactone, oral or transdermal nitrates or hydrogen should be considered. And those I'll say with high sympathetic tone, you have to look whether there's a stress, pain. Beta blockers or carvedilol or nivolumab should be considered in this group of patients. Diuretics to be considered in the patients with spironolactone, especially with cancer with hypertension and evidence of increased fluid retention. So, but in that case, one have to be careful to monitor the BP, electrolytes, and renal function in this subset of the patient. So, if we say before cancer, it should be a personalized therapy for the patient. So, before cancer therapy, a standardized BP measurement has to be done to go for a lifestyle modification and initiate therapy if it is more than 140 by 90 and the goal to be kept below 130 by 80. And if you are suspecting any secondary hypertension, go for that, evaluate for that. Once it's optimized, there should be a close BP monitoring. The first line as already told with ARB or ACE, then calcium channel, then thiazide, diuretics, and to manage the comorbidities. If the patient is having diabetes, proteinuria, you have to manage it adequately and the pain and anxiety. And maintenance after cancer therapy. So in that case, if you are shortly after stopping anti-cancer therapy, you may need to rapidly reduce the antihypertensive drug. So avoid hypertension. So be careful about that you may have to also decrease the result, and a close monitoring for development of hypertension and associated target organ damage has to be taken care. So encourage home BP monitoring with education and proper techniques and assess for all the toxicities, the comorbidities the patient is having. So if we consider the guidelines, so they also say that ACE inhibitor ARB the first line with the recommendation of level of evidence 1B, calcium channel being the second line in these, and combination if there is 160 by 100 of the BP. Diltiazem and verapamil are not recommended for arterial hypertension in cancer because due to high drug-drug interaction, that's important. And effective treatment of cancer therapy induced arterial hypertension should be there to prevent any cancer treatment interruption, targeting BP less than 140 by 90. And in selected cases, only if it is more than 180 by 110, then only you have to use hold the cancer treatment. Else, it's okay, you can continue with the treatment in all the subset of patients. So with this, I like to end my talk. Happy to take any questions from Kumar.
Thank you, Dr. Amit, Kumar, for your nice talk. So we are in shortage of time. Maybe we can take one question from the audience.
Yeah, can I ask you a question, Dr. Amit?
Yeah, please, sir.
Yeah, I just wanted to know that why do you delay treating hypertension in patients who are having metastatic disease and decreased survival? Why is the threshold increased in those particular patients?
So there are multifactorial things which comes in play. So if a patient is having a metastatic disease and we have the survival is decreased, so we might be having pain, more stress. And in that case, the long-term outcomes, basically we are treating hypertension to prevent the target organ damage that the nephrotoxicity or the cardiotoxicity or vascular toxicity is causing. So if we already suspect that the patient is having a survival less than a year or so, so in that case, the control should not be as rigid as a patient who is having a normal survival or a long-term survival. So we may just defer for a cutoff is slightly raised in this group of patients.
The only thing what I think is that because all this treatment, I'm a cardiologist, basically. I am an interventional cardiologist, and at the same time, I was interested in cardio-oncology also. That's why I joined the group. And at the same time, I think that treating hypertension, I don't think so that we should really wait for in these particular group of patients where we find that the survival is limited. I think so we can be more aggressive also in treating them so that at least one comorbidity can be taken care of well.
Yeah, so in those patients, basically with a low, the cutoff is mostly like around 150 by 90. So we are just waiting till that. Ever that, surely we are going to treat even in all the patients.
Thank you.
Thank you, sir.
Thank you, Dr. Amit. I am Dr. Subrata Mistry, senior consultant cardiologist. I have a question to you like this, that if a hypertensive patient is on chemotherapy and there is blood pressure is high, so in the measures you have talking before, that lifestyle modification or the oral drugs, they will take time, at least 72 hours to come down the blood pressure. So if we need the immediate measures, then what will be the better? If the IV metoprolol or IV nitroglycerin, which will be the better in a CCU setting?
So if in the CCU, nitroglycerin, I think so best, but only with IV level labetalol, you are able to control the blood pressure if you are planning. So that's the easiest drug to be given, and the dose can also be given at an intermittent of 5 minutes if the BP is not settling. So for all clinical practical purposes, we are using labetalol, but if the CCU setting is there, you can give an infusion. Nitroglycerin is the best thing for any hypertensive emergencies.
In the real practice, the oncologists used to ask us to get down the blood pressure within very short time. But with the oral management, it is not possible. So the oncologist should think about that. Thank you.
Yeah. So surely if the blood pressure goes something in basically hypertensive emergencies going more than 200 or by 110 or so, in that case, surely IV should be given. But below that, I think so amlodipine giving to the patients and waiting for the patient for 30 minutes or so, you can just in the OPD setting also one can control the hypertension.